Before we introduce our speaker of the day, a couple of comments. Today we want to remember and celebrate Theodor Schwann, Schwann. You know that name. He was born on this day back in 1810. He was a German physiologist who founded really modern histology by defining the cell. This was 1839. So he defined the cell as the basic unit of organs. And that sort of developed the foundation for cell theory and so forth. He was well known for work on fermentation. He discovered pepsin, for those GI folks in the room. And Schwann cells in the brain are named after him. Okay. We also remember Sir William Jenner, Jenner. He died on this day back in 1898 at age 83. He was an English physician who distinguished between typhus and typhoid. And you may think that's simple now, but back in the 1800s, that wasn't clear. So he actually did an autopsy of 36 patients in the London Fever Hospital. You can imagine why it's called the London Fever Hospital. People came in with fever, and they had to figure out what it was. And he made it clear that these were two very distinct entities that we were inappropriately treating because we were just considering them the same disease. Martin Rodbell died on this day back in 1998, just a few years ago at age 73. He was an American biochemist who was awarded the 1994 Nobel Prize for Physiology and Medicine for having discovered with Alfred Gilman G proteins. Need to say no more. And then Herbert Spencer. I want to spend a minute or less about Spencer because we don't know as much about him. But he died this week in 1903 at age 83. He was an English sociologist and philosopher. And he really believed in the theory of evolution. So he felt that organisms and societies sort of evolved from a primitive state to a very heterogeneous, complex state. He also felt that knowledge, remember he's a sociologist, philosopher, knowledge evolved in the same way from a very simple understanding of something to a very complex understanding and the evolution of scientific knowledge into specific sciences and so forth. And he developed all these things way before and different and separate from Darwin, who was actually overlapping because Darwin was here between 1809 to 1882. And he was the one who coined the phrase survival of the fittest. It was Herbert Spencer who coined that phrase 4 years before Darwin did the natural selection theory. And finally, on this day, back in 1884, giving you another quote, during a lecture at the University of Lille, Louis Pasteur, you should know who he is, made his much quoted remark, in the fields of observation, chance favors only the prepared mind. And with that, I'll give you Andrew DeFilippis, who's going to introduce our speaker of the day.
Good morning. So I think all of you should be familiar with today's speaker, Dr. Ikram, who initially completed all of his medical training in Pakistan, but then came to the U.S. and completed another internal medicine residency, cardiology fellowship, interventional cardiology fellowship, all here at the University of Louisville. Excuse me. And then went on to do advanced training in peripheral interventions at the famed Washington Hospital Center in Washington, D.C. He's been a gratis faculty member here since 1995 and then became a full faculty member in 2004. Since that time, has had multiple leadership positions, really too many to enumerate, but some that stand out. He is our Interventional Cardiology Fellowship Training Director for many years. He served on committees to improve how we handle patients with chest pain in our chest pain center, acute myocardial infarction, the CCU, and the list goes on. He's has multiple publications, including multiple publications on today's topic of stress cardiomyopathy or Takotsubo. It is clear from looking at his list of publications that he is used the publication to teach our fellows, both in general cardiology and in interventional cardiology fellow scholarship. And most of all, he's one of our senior master clinicians, someone I turn to and rely on, and many of us at earlier mid-career turn to with difficult clinical and scholarship questions, and he is always very generous with his time and advice, and I look forward to his talk today on stress cardiomyopathy. Thank you.
Thank you, Andrew, and thank you very much, Jesse, and the audience for inviting me for this topic, which is becoming very common, and actually more and more awareness is being shown to this entity now. So what I'm going to talk about is stress cardiomyopathy, and other names for this condition are stress cardiomyopathy, apical balloon syndrome, and broken heart syndrome. I have no financial disclosures. So I'll go with the format that Dr. Roman has essentially laid out now for most speakers, and I think it's we'll start with a case, and then I'll come back to these cases, and then we'll see what we have. So the first case I want to present is a 62-year-old female. Typical multiple medical problems of diabetes, hypertension, heavy smoker who stopped smoking 6 weeks ago, had history of cancer with colostomy, radiation treatment, chemotherapy, chronic anemia, etc. And she presented with substernal chest pain, which was radiating to her left arm, neck, and back, associated with diaphoresis, vomiting, and dyspnea. She said this pain was different than her previous pain of gastroesophageal reflux disease, and this time she said it was like 20/10 was the severity with partial but immediate relief with sublingual nitroglycerin. So she was anxious, otherwise her exam was unremarkable. Her vital signs were stable, heart rate was slightly tachycardic, her WBC count was normal, and rest of the labs and her cardiac enzymes came back elevated with a CKMB of 4.7, and troponin initially was 0.2 and then elevated to 1.8. So she was admitted with the diagnosis of NSTEMI, and an ACS protocol was initiated. This is her EKG, and as you can see, not very remarkable. It's a normal sinus rhythm. She has slow progression here, so slow septal progression. Otherwise, quite unremarkable. We didn't see any obvious ischemic changes. So I'll go to the next case. This is a 41-year-old female with a known CAD with a stent to the LAD 9 years ago. So she was only 32 when she had a stent 9 years ago. She carries a diagnosis of HIV/AIDS, active cocaine and alcohol use, admitted with intermittent chest pain for 2 days, worse with exertion, and radiating to jaw, left arm, and associated with shortness of breath. She admitted using crack cocaine 2 days ago. Her run sheet showed elevated blood pressure of 190 to 225 systolic, and very elevated diastolic blood pressure of 120 to 152. Heart rate was again tachycardic, but regular. She was a little labored in her breathing. Oxygen saturations, however, were normal, and a very thin lady with a BMI of 18.6. And you see her labs, platelets were low, and her CKMB came back 2.8 and then rose to 20.4. Troponin again elevated from 0.7 to 5.8. This is her EKG, and as you can see, especially the house staff, that she's got ventricular bigeminy every second beat. So sometimes it's hard to appreciate the EKG changes. But if you look at the normal beats here, she had pretty impressive ST elevation in the anterior lead. So V1, V2, V3, V4, and then so very remarkable. And sometimes if we have frequent PVCs, we can give some lidocaine to settle down the PVCs and see. So that's what we did, I think, in the ER. She got it. And then you can see now that ST elevation, what we call tombstone, very impressive ST elevation in these anterior leads. Next case is an 80-year-old female. I'll come back to these at the end of the talk. So we'll quickly run through these. This is a lady, my clinic patient, very anxious lady with history of hypertension. She went to a primary care physician's office and complained of some chest pain to the primary care physician. And an EKG was done, which was thought to be abnormal, and she was sent to the ER. When she came here to the ER, her blood pressure was on the lower side. It was 86, heart rate was 90, but she was doing fine. She just mentioned the chest pain to her physician, but when they did the cardiac enzyme, her troponin was again 4 and 4.9. And they got an EKG again in the ER, and as you can see that she had some changes here, slow progression. She has chronic lung disease also, but you start seeing these changes of anterior MI and then ST elevation in V1, V4. That's what they observed in the family medicine office also when she went there, so she was sent to the ER. Last case I want to show is a 68-year-old gentleman who also has a history of hypertension and anxiety, depression, with a recent stress due to his grandson's illness, and was at work and collapsed there, and was presented to an outlying hospital. He was intubated for respiratory changes and mental status changes. CT scan was negative. He was originally admitted to MICU service and treated with norepinephrine and dobutamine with improvement. And they also did a lumbar puncture due to his mental status changes. And on examination, when he came here, he was intubated, and his blood pressure was stable. And again, when they did the EKG, cardiac enzymes, his troponin was 1.5, 4.3, so slightly elevated, or moderately elevated. And this is his EKG. So he has normal sinus with a right bundle branch block. And I think this was not a change from his previous, I'm not sure exactly, but I think this was chronic. So on repeat EKG, there was no significant changes other than a right bundle branch block. So I'll come back to these. So the topic I want to discuss is Takotsubo's cardiomyopathy, which is actually a transient systolic dysfunction, typically seen in the apex and the anterolateral mid segments of the left ventricle, and that mimics MI in the absence of obstructive coronary artery disease. I won't say absence, I'll just change it in the absence of significant or acute coronary syndrome, meaning that there's no plaque rupture in the artery, but you can still have coronary artery disease, but typically, in majority of the cases, there's no coronary artery disease. So this is not a new entity. It has been observed since 1990 when Dr. Sato in Japan identified this condition, and he attributed to a multi-vessel coronary spasm, and he identified or presented these 5 cases where they found that in 4 out of these 5 cases, there was a significant spasm. In 2 of them, they spontaneously, and then also after they gave ergonomine administration, so they found significant coronary spasm, and it was attributed that it was probably an NT, and the coronary angiogram was normal in these people. So it has been there for 27 years. So why is it called Takotsubo's cardiomyopathy? It is a Japanese term named for an octopus trap, which has a shape that is similar to the apical balloon configuration of the left ventricle. So it's narrow at the neck and wide at the bottom. So once the octopus goes in, it cannot come out. So that's why it's named after that. And that's the typical type of Takotsubo's is when you have the apical and mid to distal anterior wall hypokinesis, and sparing of the base of the heart, which actually is hyperkinetic, which is a typical variant. But now we are identifying numerous variants of this entity also. So as you can see here is that typical, this is the trap where you have narrow base and the dilated distal portion, and they catch the octopus in this way. So here's a schematic diagram that here in a normal heart where everything is contracting, this is the myocardial wall, and whereas you see in Takotsubo's that all these areas are hypokinetic, whereas the base is hyperkinetic in its typical variation. And if you look at the LV angiogram, it's pretty dramatic, that almost there's a severe hyperkinesis, or obliteration of the cavity, especially if someone has some left ventricular hypertrophy, but then there's a apical ballooning which is why it got its name as the apical balloon syndrome also. So less common variants, I already mentioned that there are many variants now we are seeing, and in fact about 1/3 of the cases also involve the right ventricle. Initially we didn't know the right ventricle was involved, but now we see that almost in 30% of the cases right ventricle is also involved. So here different, again diagrammatic, this is the typical type, and here you see the apex is contracting, but the base is not contracting. Here's a mid-ventricular type, and there's a localized type. So multiple variants are seen now. So how common it is? It is much more common in women, and in one series it was reported to be 80 to 100% women with mean age of 61 to 76 years. So I was giving a talk one day, and the women, one of the women, she said, you know why it is so common in women? Because 80% of the men don't have a heart. So that's why it's. So anyway, so what is the pathogenesis? They've been attributed to, like we mentioned, that Dr. Sato in his paper thought it was coronary spasm. Then there's hypothesis that what triggers it is basically an acute illness or an intense emotional stress of some kind. Many times the patient don't say that, but once you get a more history, you realize that that there is something has happened which has triggered this, and it could be any such devastating bad news, and now there's some data that even positive emotions, like someone is very happy or can also develop stress cardiomyopathy from that, but typically seen in a negative, with negative news or something. Pathogenesis is still not understood, and one thing they have noticed in numerous studies is the catecholamine storm or elevated levels, and microvascular dysfunction, as we mentioned in earlier papers, and also as we mentioned, the catecholamine excess. So there's a dynamic mid-cavity or left ventricular outflow tract obstruction. So what they're saying is that sometimes when the base of the heart is contracting so vigorously, it pops out the apex, so that may contribute to the apical ballooning, just the mere fact that the base is contracting so rapidly. But these are the three main postulates that have been described as a pathogenesis. So what is the support for catecholamine? And they saw that when they did catecholamine levels in Takotsubo's patient compared to MI, they were significantly elevated in people with stress cardiomyopathy compared to people who presented with myocardial infarction, like a STEMI was there. So also they found that people with pheochromocytoma, they found a similar cardiomyopathy in patients with pheochromocytoma, and also in the setting of acute brain injury, which triggers a autonomic or catecholamine response. So they saw similar things in that favor. And when they did the pathological data, and if any pathologists are here, they found that there's interstitial fibrosis, mononuclear infiltrates with contraction band necrosis, accumulation of glycogen, vacuoles, disorganized cytoskeletal and contractile structure, and increased extracellular matrix proteins. All these entries, these pathological or histological findings completely resolved after the functional recovery. So they did the biopsy again. And in a mouse model, it was found that, as we all know, that epinephrine catecholamines are positive inotropes, and that positivity is due to beta-2 receptor-mediated GS protein, which is positively inotropic, but it switches to a negative. Once there's a very high level of catecholamine, it can switch to a negative inotrope because of the signaling to G1 protein instead of GS protein. And there's more concentration of these beta receptors in the apex. So one postulate is that when there's a storm, it affects mainly the apex because there's a signaling from GS to a GI protein. So that they did that in an animal model. What is the evidence for vascular dysfunction? And again, we see coronary spasm on angiography, and also when they did the perfusion scans, it showed that as the myopathy improved, the perfusion scans also improved. So there was a microvascular dysfunction happening in these. So another thing which we do in the cath lab is what we call a TIMI flow. TIMI 0 is no flow, and TIMI 3 is that thrombolysis and myocardial infarction. It's a category of the blood flow in the arteries, and TIMI 3 is normal, TIMI 0 is no flow, TIMI 1 and 2 are slow flow. And we can count the number of frames it takes for the dye, angiographic dye, to reach a certain point in the artery. So we have predetermined points in the artery, and we measure the amount of. So we did a study, and there was interest in whether a slow flow in the artery is due to microvascular dysfunction. And so we published or presented an abstract. I think, Andrew, you were there in that ACC meeting. That we found that when we had 16 patients, and we measured the TIMI frame count in those 16 patients and compared it to normal controls, and we found that in our study, the left anterior descending artery had a slow flow, meaning there were more TIMI frame counts in the LAD. That was suggestive of a microvascular. The arteries were clean, and just like a normal angiogram we compared, but the flow was there. So that was also one indication that there's a microvascular dysfunction going on in these papers. So that resulted in a publication a couple of years ago, and it generated some interest. So Dr. Yalta and his group wanted to know if there is prognostic implications. We don't know if there's prognostic implication of this down the line, but there is postulate that people with Takotsubo's cardiomyopathy can develop recurrent Takotsubo's cardiomyopathy. And however, we know that there's prognostic markers such as copeptin and terminal fragment NT ratios. And also, if you see prolonged QT interval, that is a bad outcome, that things like myocardial stunning, cardiovascular arrest, arrhythmias can happen in those patients if you see those. But in our, we didn't know what implication just the slow flow may have in the long run. Also, another interesting comment on our paper and then subsequent publication was that there was a low prevalence of diabetes in these subset of population. So one thought was that diabetes causes negative, it blunts the autonomic response. So typically, if you look at all the patients who present in CCUs and with acute coronary syndrome, about 30% are diabetics, whereas in stress cardiomyopathy, that number was almost half. So that we had the same observation in our data. There were less diabetics, and again, it was postulated that diabetes may have a protective role actually against Takotsubo's from blunting the catecholamine response. And people have said that what if it was a ruptured plaque and then it resolved? By the time you take the patient to the cath lab, you do the angiogram and there's nothing. We don't know. But typically there are markers. We can see the thrombus, we can see other things, distal embolization, and that is more technical, but we don't know. But generally that is not considered a typical scenario in stress cardiomyopathy, that you have a ruptured plaque and then it dissolves and then things happen. Familial, yes, there's some data. It has been reported in 2 sisters in one family, mother and daughter in another family. However, genetic analysis have not identified a polymorphism or a mutation. Critical illness, they did a study in 92 patients admitted to MICU, and they found that 26 out of those patients had LV apical ballooning. Actually, in some hospitals, centers, every person who gets admitted to MICU gets an echocardiogram. Because if your patient is not doing well and everything is going well, your infection is under control, and you have patient not doing well, I think they may have a possibility of stress cardiomyopathy. The good thing is that it resolves in most people within 7 to 14 days. And but during that particular time, they have to be treated very aggressively, like an acute coronary syndrome patient. It's seen in about almost 2% of cases presenting with acute coronary syndrome. So it's not minuscule. I have now personally seen probably 40 cases of stress cardiomyopathy, and all the cardiologists in town are seeing this on a quite common basis. So what is the clinical presentation? Clinical presentation is very much like an acute coronary syndrome. Typically, patients have chest pain, they can have shortness of breath, syncope, and the findings are EKG abnormalities. Most EKG findings are ST elevation, myocardial infarction. And then again, when you do the echo, you may see the findings that we described earlier. So again, ST elevation is noted in almost 35 to 55% of the patients, but EKG can be normal. And also you can have prolonged QT syndrome, and abnormal Q waves can develop also. So troponin is typically elevated. However, the numbers are not that high. In one series, it ranges only up to 1. If you look at the LV on the angiogram or echo, there's a huge, massive, LV dysfunction. And in those kinds of scenarios, we have seen that if someone occludes their left anterior descending coronary artery and the whole, the troponins are in 200s or 150 or up out of the range. Whereas in these, it's a dramatic dysfunction, but the troponins are only elevated. So it's suggestive of some kind of a demand kind of ischemia rather than transmural infarction, which we see in the others. Again, LV function we know can dramatically drop from up to 20% to 49%, and then it can recover luckily in most patients. So we recently published a paper last year where it was with anesthesia department. A patient came for a tracheal stenosis evaluation or treatment, and this lady had a motor vehicle accident with a prior subdural hematoma and subarachnoid hemorrhage, and that can cause a post-traumatic stress syndrome kind of a situation. It's a neuropsychiatric disorder triggered by subdural hematoma. And so as soon as she was given anesthesia, she went into acute heart failure, and then we found that she had a reverse Takotsubo's cardiomyopathy, where the apex was fine, but the base was hypokinetic. So it was a reverse type of so a lot of studies are being done now on different varieties of these. And again, LVOT obstruction was seen in many of these patients. And again, as we know that when there is a significant outflow tract gradient, then the mitral valve gets pulled into the stream of the aorta, and you see the mitral regurgitation also. So now you have another problem that not only you have LV dysfunction, you have LVOT obstruction, you have mitral regurgitation, which we call SAM. It's systolic anterior motion of the mitral valve. It gets sucked into the aorta. So Mayo Clinic has done a risk score, as we are doing scores in everything these days. So if someone is more than 70 years, they have a physical stress LV of 40%, these are the people who develop acute heart failure. So if you have these three variables, then the risk of a heart failure is almost 85%, whereas less than 10% if you don't have any of these. So again, anyone who presents in an acute coronary syndrome after some kind of a stress, one should think of this diagnosis now. Again, it's the same thing that I have discussed earlier. So what is coronary angiography? Typically shows normal or mild to moderate atherosclerosis, and obstructive CAD may rarely coexist by virtue of its prevalence. As you know, this is an older population. Typically, we see about 60 or so with the underlying risk factors. So coronary artery disease may have, and we have to be careful that, whether it is a stress cardiomyopathy or it is something there. And actually, I'll show you, we published a paper on that also. Cardiac MR is a very good modality now. You see enhanced gadolinium enhancement, which is basically identifies the scar. And when they did the CMR on stress cardiomyopathy, they didn't see any gadolinium enhancement, whereas they saw that in true myocardial infarction. Also, a good marker to identify thrombus in Takotsubo's cardiomyopathy. Again, Mayo Clinic has come up with a diagnostic criteria that there's a transient hypokinesis, the absence of CAD, new EKG abnormalities, moderate elevation in cardiac, and absence of pheochromocytoma are required for the diagnosis of stress cardiomyopathy. So what do you do when the patient presents with the stress cardiomyopathy? Now it's a dilemma. A person comes with acute coronary syndrome, ST elevation. What do you do? Well, in a PCI hospital, you take them to the cath lab, and because we don't know whether it's an acute MI with an occluded artery or it is a stress cardiomyopathy. So in non-PCI capable hospital, just like we do now, that if I get a call from somewhere in Litchfield, Kentucky, where I know that it will be 2 hours, I can give them thrombolytics because there's no obvious contraindication to giving thrombolytics. And in hospitals where you have neither of those, you just treat them aggressively with all the supportive measures as you would do and try to transfer them to a tertiary care hospital. And RV involvement is always, as also now seen in almost 30% of the patients. So what is this treatment? Treatment is the same as you would treat an acute coronary syndrome with acute heart failure with beta blockers, diuretics, and aspirin, and coronary angiography to make sure there's nothing that you can do intervention-wise. So if someone has no LVOT obstruction, you can use pressors. You can use dobutamine and dopamine. However, if someone has LVOT obstruction, it's dangerous to use inotropes. But to decrease the LVOT or to decrease the gradient across the LV, we can use phenylephrine or beta Epi or alpha agonist, so that the SAM or the mitral regurgitation can get less. Thromboembolism. So as we know that these patients have sudden, profound LV dysfunction, and in acute coronary syndrome, they can develop a thrombus very quickly. So in one series, they suggested that for 10 days of anticoagulation may be useful in Takotsubo's, whereas as we know that normally if someone has LV thrombus, we give 3 to 4 months of anticoagulation. But in Takotsubo's, it's not a standard treatment because it's resolving within a week to 2 weeks, hopefully. So in that short period of time, if you see a thrombus, definitely. But to prevent a thrombus, it's controversial, but people have used that. Prognosis is very good. In fact, majority of the patients recover their LV dysfunction within 1 to 2 weeks. So we don't have to get very aggressive with multiple things. It's a good idea to repeat an echo in 4 or 5 days and again and see what's happening. And but still, it's an acute coronary syndrome-like situation where you can have arrhythmias, you can have LV dysfunction, syncope. There's a mortality can be as high as 8%. And but in these days, when they get to the hospital quickly, it's probably much less. So let's go to our cases now, which we discussed. So this is our first case, and this is a lady, 62-year-old, with multiple medical problems, who was anxious, presented with chest pain, which she says was 20/10, much different than her acid reflux symptoms. So what did we see in her? So this was her EKG, as we saw that nothing remarkable except some slow progression here. And so this was her echocardiogram. I hope it plays. All right. So this was her baseline echocardiogram. As you can see, this is the left ventricle, right ventricle, mitral valve, left atrium, tricuspid valve, right atrium, interventricular septum. So you can see that right from here, there's severe hypokinesis of the wall. The base is moving much better, but from here onward, which is the territory of the typically left anterior descending, so the apex is kind of disconnect. It's moving almost out. So this is very suggestive of a problem with her. So let's see what her. So we took her to the cath lab, and this is her coronary angiogram, completely normal. So that's the left anterior descending artery. This is the left anterior descending artery going all the way to the apex. So if someone has an echo like that, you would see an occlusion of the coronary artery. This is the circumflex artery. So again, not much there. And this is her right coronary artery, which we don't expect, with the anterior wall motion to have any problem with that. So and as we suspected, there was nothing. Sorry, there was nothing in the right coronary artery. So very large dominant right coronary artery. The artery that gives the posterior descending branch is the dominant. So this is the dominant right coronary artery, and we didn't suspect anything like that. So this is her LV gram. We didn't see any obvious thrombus. We are careful when we do the LV gram. And here it is. You can see the very typical presentation. Like I said, she has this catheter from her chemotherapy. So here you see the apical ballooning, right? Just like the picture that we said, a very rapid contraction of the base of the heart, but ballooning of the apex. So very suggestive of stress cardiomyopathy. This is our echocardiogram a week later. If you remember the first echo, I'll show you this echo. So here now you see it's completely recovered. So now you see the where I was showing you from here on. Now you see the endocardium almost, it's hyperdynamic now even here. So she completely recovered in a matter of a week or so. So that's what it looks. And her EKG, you start seeing some changes. Remember that she had some slow progression, but now you start seeing these bifid T waves suggestive of a resolving acute coronary syndrome, which we also see in acute myocardial infarction. So she has some changes, but it's resolving. It's getting better. Let's talk about the next case. This was our young lady who had a stent when she was 32 years old. Unfortunately, still using actively cocaine, and presented with chest pain, shortness of breath, mildly elevated, and pretty dramatic EKG abnormalities as we saw, tombstone EKG changes. So this is our echocardiogram. Similar situation that you have this whole segment of the distal septum, apex, not moving, plus she has a thrombus. She has a left ventricular thrombus. You can see that it's attached to the lateral wall. So now we have the base contracting very well. Right ventricle is contracting very well. Small right ventricle, nothing in the right. Right here, all the way. And then there's a pretty impressive thrombus sticking to the lateral wall. So we took her to the cath lab as an urgency. So here's something very interesting. So here is her left circumflex artery, very dominant artery. And here is a marginal artery. There's no LAD. I don't see left anterior descending which goes like that. So that was concerning. And this is her LV gram. Try to stay away from that thrombus. So the base is moving again, but we don't see again you see the ballooning like syndrome, ballooning like phenomena of the apex right there. So that's the catheter that we are using. So this lady had an acute thrombosis of her previous stent. Now I see the LAD after I intervene. You can see there's a thrombus. See that filling defect in that area there? So this was what we were seeing before, but now you see the left anterior descending artery going up. But they're not a normal flow. The flow is still a little bit sluggish because of the reason that she thrombosed her stent. And you see these whitish spots up there. So she has a thrombus of the proximal LAD, so it's called late stent thrombosis. You see that, so I stented her, had to re-stent her again, and you can see that now the flow is normal, and so that's what it looks like now. So she had complete occlusion of her. So this is not stress cardiomyopathy. This is acute anterior MI. So that's why it's important that the echo looked exactly the same, and the LV gram looked the same, but we saw that she had a problem. So this is her EKG. You can see the resolution of the ST elevation. Now you see this T-wave inversion, which is typical, progression. And this is our echocardiogram after, a month or so. And you can see that so angioplasty does work. You see the completely normalization of her. You still see the thrombus, but it's completely normalized her So case number 3. And so this was the 80-year-old female, my clinic patient, very anxious lady who comes in, and family medicine saw an abnormal EKG, sent her to the ER. So here's the EKG again, some ST elevation from V3 to V6. And here's her echocardiogram. So the first case was a classic Takotsubo, second was an acute coronary syndrome. And this lady, again the same situation, that she has severe hypokinesis of the apex, base is moving very well. So again, we took her to the cath lab, and this is interesting, that this lady has coronary artery disease about, can you see the pointer? About 50% here, and that's almost like 70-80% here, another 50% here. So this is a concomitant coronary artery disease in a patient who is presenting like a stress cardiomyopathy. She's sitting and talking, and she said, I had some chest pain, they sent me to the ER. But when I see her troponin is elevated, she has ST elevation. She has some left main disease, you can see right there. And at the beginning of the angiogram, a little bit here. Then she has a 50% here, then almost 70-80% there. So my fellow said, let's go and fix all these lesions. I said, let's think about it. This lady looks fine. This looks like chronic to me. So let's do some other things. So we took a picture of her right coronary artery, which we didn't suspect. Again, she has some disease in the right coronary artery. As you can see that she has a 40-50% lesion here, and then nothing downstream. This is her LV gram. Very classical Takotsubo's. So I said, if someone has an LV gram like this, their troponin should be 150, not 5. So this is a complete dyskinesis of the mid to distal anterior wall. It's a massive MI. She's not having an acute MI. Those are incidental findings that we are seeing. Then I said, let's look at what if I need to, you're doing left main, you're going through the left main, you have calcified lesion. Let's look at her abdominal angiogram to make sure that she has. So you'll see that what we found is that this lady has severe tortuosity of her abdominal aorta. Her iliac arteries are all tortuous. You can imagine that my catheter is going through that. If I have to put a balloon pump, it has to go through this, take this route. She has 2 aneurysms of her abdominal aorta, which are luminal. These are actually not, we don't even know what the size of these aneurysms are, because what you're seeing is just the lumen. You're not seeing anything outside the lumen. There is suggestion that this is the outer wall of the aorta, which may be a thrombosis, thrombosed. We see clotted aneurysms all the time. So if this lady had, during intervention, if she would have crashed, you would have had to put devices and all those things. And patient who presented in a clinic with some chest pain can end up in a very bad situation. So this is, I said, let's hold off. There's nothing urgent. Let's repeat her echo in a few days. And this is what we did. Here's her echo. And completely resolved with medical treatment. This is 5 years ago, so I see this lady in my clinic. I saw her actually 4 weeks ago. She's completely fine. So the point is that we don't have to rush into. So her EKG, as you can see, like others, started resolving. These are the EKG changes. And actually, we published this, presented an abstract, and that also resulted in a publication that it's a diagnostic dilemma versus acute coronary syndrome. Sometimes you have to know what it is. Last case, I think I'll have some time. So this is the elderly gentleman who was at work, passed out, mental status changes, intubated, had an LP, went to MICU, and so this is, his white count was also elevated, troponin was slightly elevated, and so these are a right bundle branch block changes. This is his echocardiogram. As you can see, another situation where you see a very pronounced LV dysfunction. EF is probably 20%, and you see the typical scenario. So he also went to the cath lab, and normal coronaries. So here's the left main. Here's the left circumflex and marginal arteries. Here's the left anterior descending artery. And he had some disease in the right coronary artery, but nothing to explain his profound LV. So probably 50-60% lesion here in the right coronary artery, but that doesn't explain his LV dysfunction. So here's his LV gram. And you can see that he has the same scenario, hyperkinetic base and mid to distal apical segments are very hypokinetic. And this is his echocardiogram a week later. Gone. So it's normal again. So these are the 4 cases I want to show you. One classical Takotsubo. Second is HIV, which actually is an acute coronary syndrome. Third was the lady with concomitant, significant-looking coronary artery disease. And the fourth is a gentleman who had that. So it's an increasingly reported syndrome, typically triggered by an acute medical illness or intense emotional stress. It could be due to catecholamine excess, multivessel spasm, or microvascular dysfunction. Up to 2% of acute coronary syndrome. Diagnostic criteria is these remarkable wall motion abnormalities, EKG changes, but normal, typically angiograms. It can result in shock, heart failure, alveolar obstruction, tachycardia, arrhythmias. In-hospital mortality is 2%. And typically people who recover in 1 to 4 weeks. Largely supportive angiography should be performed in all eligible patients to rule out CAD. Predominantly occurs in postmenopausal, but also occurs in men. So some men do have a heart. So thank you for your attention. Thank you, Jesse. Henry.
Sohail, thanks for the great presentation.
Sure.
A couple of things. I had one case of a lady whose son died in a house fire. Came to the hospital classes like your case. I really enjoyed your case of concomitant coronary disease, and Andreas Grunstein would be very happy if you did not use the oculostenotic
Reflex. Yeah, actually, I was, you're in a very difficult situation in the cath lab many times. That here you see the fellows are ready to put 3 stents in the LAD through the tortuous, but it doesn't make sense that someone who is sitting, talking, has no chest pain, presented with something, and troponin is 4, where it should have been 400, and it didn't make sense to me. So I said, let's do it. It's not urgent. If she was hemodynamically unstable, I would have stented the LAD. But
There aren't too many advantages to great lastly, can you talk about your lady? This is not really the Takotsubo, but for the residents and training, and for me also. It's always a dilemma when someone comes in with cocaine about they need beta blockers because their muscles weak. And I think that you need to differentiate between acute cocaine toxicity
right.
versus chronic habitual use. Tell us a little bit how you approach that with whether you use Cardiovascular or beta blockers in that.
Right. So, that second lady obviously was acute coronary syndrome. I mean, she would have died, if you had not fixed that LAD, she was going down. And so, as we all know, that cocaine itself is like epinephrine. So, it's another catecholamine surge in addition to the acute coronary syndrome. So, we are cautious in using those because, you have to decrease the catecholamine. But in that lady, it's not acute, stress-related excess catecholamine levels, but from cocaine it could be like that. So calcium channel blockers is a good, and people have used, beta blockers still, although it is cocaine, is labetalol or combine alpha plus beta adrenergic blockages. So I think there's no clear cut. The problem that I see in cocaine is they have more coronary spasms. So if you are treating them with angioplasty, there are more thrombus formation in people with cocaine. There are more spasms of that. So it's more problematic from dealing with that point of view. But other than that, I stay away from solely very strong high dose of beta blockers. You give them a low dose until they recover, and you're watching them. So there's no real, I think, prescription for those particular patients. You do try to avoid any adverse unopposed action. So Thank you. Again, Mayo Clinic criteria did say if there's no clear cut, because the pathogenesis is all speculative, and they are saying that these are the things, actually we find these more than before or after. If there's a way to know if someone has microvascular dysfunction. So we have seen, and Henry has seen also, that sometimes when we do a cath on people, and now there are perfusion images, there are dynamic cardiac MRs and CTs which are available now. That remember that when we see slow flow in some people in normal caths, you always wonder what's going on, whether there's microvascular dysfunction. We have done FFRs and CFRs in those people to look at the distal circulation, and now non-invasively people are doing. So I think one of the postulates is that people who have slow flow in their arteries, who have TIMI frame count like we did that study, may be predisposed. So that's one thing. So, but we are not recommending everyone go to an MR or a CT to have that. So the short answer is no. We don't know whether you can prevent it from happening or not, or whether there's any specific markers of, Andrew probably can do, he's an expert of identifying different markers. Maybe we'll come up with something, that ratio I show of copeptin and pro-BNP ratios, if those are the markers of prognosis, and if someone is sick, and we can do those studies, if they are elevated, that may be a factor. But I think on a day-to-day outpatient setting, to find out whether you are predisposed, I don't think there's any data that I know of which shows that you have to be careful that this may happen. So I think it just happens. I think it used to, they say that, I haven't watched the movie, but someone told me that the movie My Fair Lady, one of the sentence was that she died of a broken heart. So probably had stress cardiomyopathy. So yes, sir.
Something I wonder about. You showed this spasm or hyperkinesis of the group region. Hyperkinesis of that.
Base region.
And I'm thinking to myself of the Dept coupling of all these myocytes and a calcium release. Is it being blocked at that somewhere in that region so that there's no contraction and
Actually, we are seeing it everywhere. We are seeing it not just at the base. Now there are variants. We are seeing reverse cardiomyopathy. We are seeing regional. We are seeing mid-cavitary also. So it's not always, it's predominantly. What they are saying is, the only thing that I came across was that the concentration of the receptors is more in the mid to distal and the apical. And since these are catecholamine responsive negative signaling that happens, that's what happened. But I'm not aware that there's any actually blocking of the channels at a certain level, because initially it was more common, but now you're seeing it everywhere. So it could be. But I'm not sure whether there is any description of a specific junction zones where this may happen. Right. Oh yeah, majority. Right. Contractility back. I don't know. I think I have to dig into the literature more. But I didn't come across any underlying biochemical, variants. And like I said, initially people thought that why just base not moving an apex? They thought of receptors. But now we are seeing it everywhere. We are seeing it in the right ventricle, globally also. Yes. That's what is the postulated, that women somehow develop some microvascular dysfunction resulting in the slow flow and endovascular dysfunction. So basically what they're saying is spasm theory is there, which Dr. Sado did in 1990. We see that we don't give ergonomine, and sometimes it's hard to reverse the spasm. It can happen very profoundly. The other was, of course, the catecholamine, and the third was microvascular dysfunction. There's been more publications coming on that, and that's why we did that. So I think that's the postulate that if somehow we can find out that if your flow is normal versus abnormal, you may be more predisposed in that respect. Yes. I think people. Correct. So that's why beta blockers are so useful drugs, not in acute coronary syndrome, but also I think we are inadvertently treating a lot of stress cardiomyopathies with beta blockers, and we are blocking that catecholamine surges. But also, there has been, as we know, we used to treat people with vitamin E and folate and B12. I really, don't mind these people having those to improve the microvascular function, and the newer, people are proponents of holistic medicine, herbal medications. They are saying that, these coenzyme Q and those kinds of things are also good for microvascular dysfunction. So fish oils. So I don't mind using those in these people. Thank you.